So I just give you some, I guess, housekeeping announcements. So we have set up office hours on Sakai. Don't remember exactly the time, but I left it for Sunday afternoon. So hopefully you can, or by then you have studied everything and you still will have enough time to, if you have any questions, ask the questions and learn the questions before the test. Please submit your questions by Friday so I can have the answers. I will say at the latest Saturday morning, but I'll try to answer them on Friday afternoon. The test, okay, here's the deal. I'm going to try to make it easier. But easy is a relative term, right? And the reason I say that is because I have this habit of asking my student, how was the test? And I get, when they hand in the test, and they usually tell me, oh, it was hard, it was okay, it was easy. So guess what I think it is? It depends how well you study. So, right? No, but what I'm trying to say is that if your study, hear me here, if your study should be easy. Are you following what I'm saying here? It's not going to be that kind of test that you study and you're like, that was hard, okay? So I'm trying to make it that easy. All right, so that means a couple of things. The cases are going to be short, but it's very important that we review contraindication, complications. We spend some time on that. We're going to spend a lot of time on that again today in terms of hormonal replacement therapy. Know that, because even though the case is simple, it's going to have reasons to pick a specific therapy. So you kind of need to know adverse reactions, contraindications, that sort of thing, so that you pick the best choice, okay? So with that said, again, I think it's going to be easy if you study. And the reason that I wanted to make it that easy, if you remember last time, well, I think it was easy too, but most students told me, it was okay, it was a little hard. But you guys have very little time to study because of all this notes and all days and all this stuff to study. So that's the reason I'm kind of making it easy, but I know you can handle it, okay? So study, ask me questions on Sunday, and hopefully we'll have a good test on Monday. Anyway, so with that, we're exactly at 10:20, so we're gonna get started. All right, so we're going to continue talking about hormonal replacement therapy or menopausal hormonal therapy. And then we're going to finish up with osteoporosis. So we were talking about the different, and I was saying menopause per se, not a disease, but we were talking about the symptoms that woman with menopause presents. So make sure, again, you review that. And we were talking about now systemic treatment with hormones for patients that have hot flashes. So we were talking about the different products that are available, and we were talking about different combinations, and I think that's where we left it. So I'll just start reviewing where we left it and the different products, and then we'll start talking about, let me see here. And then we get started onto the clinical trials that would explain more clearly what the complications and what the concerns are related to menopause hormonal therapy. So we were talking about that in women that have an intact uterus, the risk if you give them estrogen on what we call unopposed estrogen therapy, those patients will have an increased risk of developing endometrial cancer, okay? And certainly the risk increases with duration of therapy and increases also with, the dose. And you can see there that we're talking at least 2 times the higher risk. We do know that progesterone reduces, adding progesterone decreases that risk. The problem is, and we will learn this today, progesterone is associated with significant adverse reactions and toxicity, in this population, which we'll discuss in a moment. So we were trying, so because of those findings, we're trying to use the minimal effective dose, right, in women that have a uterus that will prevent the risk of endometrial hyperplasia. So a lot of different regimens with lower progesterone doses are being studied. But there's very little data to tell us that, yes, this is good, that we can really prevent endometrial cancer in this population. So some of the things that we've been doing, again, that there's insufficient data, is we just give them progesterone for 2 or 3, every 3 to 6 months for a few days to try, and we will see in the next slide, we have products that actually have that kind of regimen, but again, not very well studied, particularly with prolonged duration of therapy. We also have tried to give, instead of systemic progesterone, vaginal or topical progesterone, then I can move, IUDs that contain progesterone, and then just giving very low doses. Remember those topical products that we went over last class? Very low absorption with no progesterone whatsoever. Again, the risk of that, and for us at pharmacy, is very important, and we'll talk about counseling for this population. So we don't know really that prevent the risk of endometrial cancer when we use it long term. So what I have here is some examples of commercial products that go over some of those regimens, newer regimens that we talked about. Continuous combined estrogen progesterone, like the Prempro, they're pretty well studied, and this particular regimen just give a low estrogen and a low dose of progesterone all through the cycle. So those patients over time do not have, or initially would have, and we'll briefly review this in a moment, breakthrough bleeding, but over time, these patients would stop having any vaginal bleeding. When we talk about continuous sequential estrogen progesterone, which we talked a little earlier as well, again, we have different products for this. The common one is Premphase, and what this does is we give the patient progesterone for 10 to 14 days, or 12 to 14 days, with a higher dose. And as we were talking, actually I asked you this question last time, what would happen when we stop the progesterone? Yes, withdrawal bleeding. Remember, I love that you said withdrawal bleeding over, right, a menstrual bleeding, because it's drugging those very good, oh good, you knew the answer. He always does. I won't ask him if he found it easy. He's an outlier. Would you be? Anyway, so those patients, that again, very well proved. We have other products that we've been, again, modifying, where these patients just get, as I said earlier, the progesterone every few months. We don't know what that does. Very important, again, to assess the withdrawal bleeding, which we'll talk about. And then we even have newer products, like for example, the Ortho-Premfest, where we give estrogen for a few days alone, then estrogen plus progesterone alone. And again, this long-term, what will do to the endometrial risk or the endometrial cancer risk, we don't really know. Here again, a list for your reference. There are products that we can use, just the progestin, including some of these preparations that are oral, some of the preparations that we can use vaginally. So why am I reviewing this? Because the bleeding patterns of these patients is pretty much the first symptom that we see that will lead to suggestion of endometrial hyperplasia and eventually endometrial carcinoma. First of all, these women need to be monitored very closely by their doctors. They do need to get checked for endometrial cancer. But as I mentioned earlier, if the patient has continuous combined therapy, the bleeding pattern is unpredictable. However, the majority of the women, they experience that just for about 6 months. Significant number in the Women Health Initiative study, which we'll review shortly, some of the women still have some spotting at 5 years. What is very important that you tell this patient is that if the spotting becomes heavy or becomes prolonged, again, that's a symptom of endometrial hyperplasia. This woman needs to be screened for endometrial cancer, even if it's before their checkup time, okay? The annual checkup time. For continuous sequential estrogen, we talked about that. We talked about having the withdrawal bleeding 1 to 2 days after the last dose of the progesterone. And also will depend again on the cycle that you're using, if you're using every 6 months, so that's when that's gonna happen. So what the patient is gonna do, any bleeding before, right, any vaginal bleeding before the stop of the progesterone, again, an indication that that could be endometrial hyperplasia. Any heavy bleeding, prolonged bleeding, or if the bleeding occurs more than, meaning it occurred at the right time, but it's prolonged, definitely a sign of endometrial hyperplasia. And then if it, of course, it occurs more than one time in the cycle, then a sign of endometrial hyperplasia, and patient needs to be referred to the physician. So make sure that you understand that and know how to advise patient accordingly. The next agent is conjugated that I have here that was recently approved, again, trying to decrease the side effect profile of the progesterone, is conjugated estrogen and vasodoxifene. This is an estrogen and an estrogen agonist antagonist. So let me ask you this. So if we're using this to prevent endometrial hyperplasia, would this product be indicated in women without a uterus? No, right? So be aware of that. So this is really for treatment of vasomotor symptoms in women that have a uterus. Again, the advantage of this product is that will decrease, right, the endometrial hyperplasia, but this product also seems to increase the bone mineral density in these patients, and because of that, it's actually approved for prevention of osteoporosis. Keep in mind, as we were going to discuss later, that really the main indication is not for prevention of osteoporosis, but it actually helps in women that have hot flashes to prevent osteoporosis. So as you would see when we go over the black box warning of these products, this product, because it contains estrogen, it has the exact same contraindications and warnings that all estrogen products, which we'll review shortly. So with that said, what I want to spend some time is understanding or at least have an idea of the, because if I tell you guys, like, there's so much data about hormonal replacement therapy, so I'm going to summarize it in a few slides so you understand the background about how to counsel these patients. Because certainly, as we were discussing last class, the presence of these hot flashes and vasomotor symptoms could be very severe in many patients, and they prefer to maintain therapy for very prolonged times, right? Remember, when you stop it, what happened when you stop hormonal replacement therapy to the hot flashes? They come back, and not necessarily come back, right, because physiologically or naturally, right, the hot flashes may have ceased, right? But when you stop it, you're causing hot flashes because you're stopping therapy, right? So you technically, again, are causing a drug-induced menopausal symptoms when you stop it. It's important to counsel the patients appropriately. So the Women Health Initiative was a very large trial. It consisted of two individual studies. We'll go first over the estrogen progesterone arm of the trial. And as you can see here, it was over 16,000 women. This is all in America. It was not an international study. And the patients were randomized to conjugated estrogen, 0.625 milligrams, and medroxyprogesterone, 2.5 milligrams daily, right? So this is the sequential estrogen progesterone. Interesting to point that this mean age of this patient, they were older patients, the mean age was 63, but the range was between 50 and 79 years of age. And the study needed to be stopped prematurely at about 5 years, because what we found was that when we treated about, and I'm giving you this so you have the perspective rather than relative risk like your books goes over. When we looked at this woman, of 10,000 women for a year, we can see that this woman the incidence is small, but it's a significant increase. This woman had more cardiovascular cardiovascular heart disease, higher risk of stroke up to 41%. Again, an increase in 50% in pulmonary embolisms. If you look at the numbers are still small, right? And we see an increased incidence of breast cancer up to 26%. I'll briefly talk a little more about that in a moment. So, so when we look at this, we're talking about just treating 10,000 women, but when we use this, right, in larger population like that, we're actually seeing that the population will have significant increased risk of all these conditions. In terms of reduction of disease, when we treat about 10,000 patients per year, we actually saw decreased fractures, hip fractures. And what it was interesting that they were trying to find was that for some reason this patient has a lower incidence of colorectal cancer. But then more specific studies looking at this finding showed that even though this patient had a lower risk of colorectal cancer, these cancers were way more advanced and presented with metastatic disease. So certainly not a good finding, even though we put it in that column. So when we look at the global index, meaning the good and the bad, right, when we treat this woman, really we will see a significant increase in adverse events in this population. So certainly wouldn't be what we want to do in terms of a national health policy. Now, what happened when we just look at conjugated estrogen in women? Would this woman have a uterus or no? No. Okay, so this is woman, right? We're not concerned here about the endometrial cancer that we were talking about, because these were patients with hysterectomy that did not need the progesterone. What happened if I just give them estrogen? And they use conjugated estrogen 0.625 every day. Again, these women were older. They were 50 to 79 years of age. And this study, actually, the results were looking not that bad. If you hear, this study was not stopped at 5 years, was stopped at 7. Again, because the outcome when we look at them were not what we were expecting, which is quite interesting as a background info. In this population, when we were giving them estrogen in observational studies, the reduction in cardiovascular mortality was up to like 50%. But again, observational studies just create hypotheses, doesn't prove a point. So this was like very unexpected. We thought that just given estrogen, particularly if you don't add in the progesterone, that we will see significant improvement in cardiovascular disease. But what we saw was very small reduction. As a matter of fact, when we look at the risk, again, we treating 10,000 women, we saw an increase in the risk of stroke, which we were not expecting that, right? We thought cardiovascular stroke and heart attacks will decrease. We actually saw a 39% increase, and then we actually saw an increased risk, a little less than with the progesterone on VTEs. In terms of reduction, yes, we see a reduction in hip fracture. We saw a reduction in the cardiovascular disease, but not what we were expecting, just 9%. And when we looked at breast cancer, this woman had a decreased risk of breast cancer. It was a 23% reduction. But what it was interesting is, as the women were kept on the estrogen, you can see how the decreased risk of breast cancer was higher early in therapy and was approaching no effect by close to the 7-year mark. So again, the study was stopped prematurely, so we don't know necessarily if maintaining long-term hormonal or estrogen replacement therapy would have actually resulted in really a significant reduction in breast cancer. But certainly at 7 years, they saw that 23% reduction. So when we look at once again at the good and the bad, guess what? It didn't really improve quality of life and put us, if we, again, treated menopausal women, it will be not really any beneficial effects in terms of preventing complications, or actually will not make a big difference. Now, when we look at the long-term data in cancer, it's actually quite interesting. As you know, the studies were stopped at 5 and 7, 7 and 5 years. But what they did, women will continue to be monitored to whatever regimen they were in the study. But remember that the estrogen therapy was actually stopped. So the participant that agreed to be continued to be monitored were significantly less. Which kind of may obscure your data a little bit. And they followed this woman now up to 11 years. And as you can see here in the patients that were given estrogen and progesterone, they still have, even after stopping therapy, higher risk of breast cancer. You also saw that even though, they had the high risk, but not also had the high risk, but the disease was also more advanced. They have more node positive, and they actually had higher mortality to breast, And keep in mind, these women are very well monitored, right? They were in a study, so when you put this in the general population, women that may not be monitored as closely as women in a study, certainly this is not a very good finding. So yes, they did have a higher mortality. When we look at the participant, 11 years that got the estrogen, they still have a lower incidence of breast cancer. But keep in mind again that the estrogen was stopped at 7 years. So we don't know. As I was mentioning, the incidence was becoming, or it was decreasing over time, or the benefit was decreasing over time. So more recent study have looked at that. And again, we're not talking studies as well done as the Women Health Studies, Women Health Initiative, but yes, it seems that when we use estrogen and progesterone and even estrogen, we may see an increased risk of breast cancer over time, particularly if, and this is significant guys, if the patients are started on estrogen therapy right after menopause. So when they start within those 5 years of menopause, this risk seems to be increased. And the reason this is significant, and I'm mentioning this, is because as you look at some of the guidelines, particularly the older guidelines that are still current, like the National Osteoporosis Foundation, they still suggest that these patients, with good surveillance, be maintained on hormonal replacement therapy. But again, we'll go over more recommendations through the lecture today. Now, what about dementia? It was very, very interesting because before the results of the study came about, women with achieved menopause and they were put on estrogen replacement therapy, and they were suggesting that if you start this, your incidence of dementia will decrease. Remember all those mood disorders and memory problems that we talked about that we don't know if they're related to menopause? So we put this woman on this drug, and we'll see, how much better you will feel. Well, when we look at the data from the randomized control trial, that actually is not the case at all. So when we look at the woman on the estrogen and progesterone, they actually, guys, have a higher incidence of dementia, like 2 times higher incidence. And even with the estrogen, and again, this is in the older women, the incidence was almost as high as with the estrogen and progesterone. When we look at the younger, we look at the younger women, 50 to 55, again, no benefit on dementia. So really, giving this patient estrogen and progesterone or estrogen alone did not really improve their outcome in terms of memory loss. So after these studies came about, certainly they needed revision for these products, and all this labeling revisions are in every product, even if they have estrogen or progesterone or just estrogen alone. They're topical, right? All the products have the same warnings regarding the findings on the Women Health Initiative. So they highlight the risk of heart disease, MI, stroke, breast cancer, and dementia. And for that reason, again, we will try to, patients that just complain of vaginal atrophy, as we discussed on Monday, we're only going to treat them if the symptoms are moderate or severe. Don't treat this patient if they have mild symptoms. And if we are going to use, we want to treat them for vaginal atrophy, we're going to use it at the, we use topical products for the, with the smaller dose for the shorter duration of therapy, right? I actually sometimes get amazed that I have patients that come to my clinic and they've been on this product for 2 or 3 years or longer and they don't want to stop it. And you need to cancel it and document that you counsel the patient and that the patient understood the risk and refused. Once again, if we're using it then for hot flashes or the vasomotor symptoms, then we can use systemic therapy. We need to use the lowest possible dose for the shorter duration, keeping in mind again that some of this patient naturally may have symptoms up to 7 years. Some patients may have symptoms lower, but they, for a shorter time. Keeping in mind again that when you stop, the symptoms will recur, and that you again document that you cancel the patient appropriately. Maybe we'll think that this risk of cardiovascular disease, and there's some data to point that the risk of cardiovascular disease in this population. Remember, the women in the Women's Health Initiative studies were older women would have a better cardiovascular profile if they're younger. So we will feel like, okay, and some data, as I said, seems to show that. However, the problem is that if we use it earlier, now we're noticing that there's an increased risk or possibility that this woman may actually, younger woman may have a higher risk of breast cancer. So overall, and you will see the change in the guidelines, particularly for osteoporosis, and we'll go over that at the end of the lecture, had changed where really estrogen therapy should not be recommended for a prolonged period of time. And the patient needs to be well aware of the risk. And I tell you that because I see my patients coming back and they come with complications and they tell me, oh, I wish someone had told me. And I'm like, yes, we told you, here it is. We documented it, you have to document it, okay? I want to use your license over a lawsuit for something that the patient decided on their own. Your goal is to, as a pharmacist, is to tell the patient the data. The patient needs to make the decision, right? But you do need to give it the data that you need to document it. And this is just to show you what the warnings are. In terms of contraindication, you probably then will know them now by heart, so make sure you do know them by heart before Monday. Stroke, cardiovascular disease, history of VTE, but we had spent some time on that, cardiovascular disease and so forth, and then any possibility of bleeding that you may suspect breast cancer or undiagnosed vaginal cancer. Certainly very important then, if you're going to put this patient in hormonal therapy, that you do a very good assessment, not only that the diagnosis is consistent with menopause, but very importantly, that the patient doesn't have any contraindications or relative contraindication. Very important that ahead of time you discuss the risk and benefits, and then obviously you do physical exams, lab tests, and so forth, including cytology to make sure there's no endometrial hyperplasia, mammographies to make sure that they don't have breast cancer. And pretty much, I'm not going to spend a lot of time on this, but pretty much this summarizes and I made you a higher chart in your objective, summarizes what we just went over. So with that, if you don't have any questions, we move to postmenopausal osteoporosis. All right, so when we talk So we really gonna limit the topic today to postmenopausal osteoporosis. Some of the data that I will give you also applies to men. We'll talk a little bit then about pharmacologic therapy, but certainly the prevention is good for men and women. And I will say, so that maybe you feel that it applies to you, as we will see shortly, it also applies to you because bone mineral density, or keeping healthy bone mineral density, is a process that needs to happen all through life, so we go over that. So when we're talking about osteoporosis, or postmenopausal osteoporosis, we pretty much are talking about a decrease in bone mineral density that leads to increased fracture rates. And very specific, this fracture, that when we're talking about osteoporotic fractures, we're talking about fracture of the hip, the spine, and the wrist. This will be significant when we talk a little bit about diagnosis. And we know that this is not associated with any other pathology, right? For example, I don't know, hyperthyroidism or malabsorption syndromes or anything like that. Really associated, if you will, with old age or with aging. So a little bit about bone and bone health. A couple of things important. Patients, or we achieve the peak bone mineral density at about age 30. So that means that you're building bone up to about age 30. The problem is that after that, you actually, even if the patient is not menopausal, you start losing bone mineral density. And what is interesting is that then during that perimenopausal, menopausal period, we experience an accelerated bone mineral loss. You can see there, this is just for your reference, we're talking about up to 5% bone mineral density loss per year. So that's pretty significant. After those years, it still continue, but it slows down. So those perimenopausal years are very critical in terms of bone mineral density loss. But what you need to keep in mind is if you didn't have a good bone mineral density to start with, right, then your risk increases. And you can see here in terms of how prevalent this is, it's very, very prevalent. We're talking about, and this is just osteoporosis percent. We've diagnosed about 10 million people in America, 33 million people with osteopenia, which we'll define in a moment, but that means decreased bone mineral density. And we see significant morbidity and mortality with this. We see about 2 million osteoporotic fractures per year, and the problem with this is particularly for hip fracture. The mortality after hip fracture is very high. We're talking about in some series up to 5% of the patients that have a hip fracture will die within that year. So it's important to keep that in mind. Cause of osteoporosis, not just of the treatment, and the treatment is very expensive, and we'll talk about that, but it's pretty high. So one of the things, and we'll discuss this in more detail when we talk about how we score the risk of osteoporosis, it's important to consider risk factors for osteoporosis, and those things that, particularly when we're deciding treatment, particularly when we have younger patients, to try to do or to modify the health habits so the patient could have less decrease in bone mineral density, or in the case of patients that are not up to 30, that they can maintain bone or achieve higher peak bone mineral density. Now, what are the risk factors? So family history is a very significant risk factor, particularly if a mother or a sibling experience this low trauma fracture. Remember, hip, spine, and wrist. Age, kind of self-explanatory. Very interesting, Asian and Caucasian patients have higher risk of osteoporosis because they have lower bone mineral density to start with. Cigarette smoking, very significant. Anyone can guess how cigarette smoking do this? We talked a little bit about last class. And I told you another good reason to stop smoking. Decreases the estrogen levels, right? Remember that we said that in menopause, in smoking, accelerated menopause for about 2 years. So pretty much makes you age faster. So yes, cigarette smoking is a risk factor. Excessive alcohol, we define as 7 drinks per week, same as excessive caffeine. Very important and again significant sedentary lifestyle and prolonged immobilization, which we see, for example, in patients in nursing home is a risk factor, but certainly aerobic activity increases bone mineral density. Patients with low body weight, prolonged calcium deficient diet, so those of you that don't drink enough milk, you still have time, get your supplements. Again, sounding like your mother, but anyway, you should. And particularly in this side of the country, right, where the light exposure, sunlight exposure during the winter months decreases, so it's important to keep that in mind. Then obviously patients that developed menopause earlier, and then drugs including steroid, phenytoin, heparin, and excessive thyroid replacement. All of those will contribute or are associated. And there's more, but I'll just give you the most common one. Associated risk of osteoporosis, and certainly patient, as I mentioned earlier, with malabsorption syndrome. The mechanism of osteoporosis, I'll briefly give you some pathophysiology. I don't want to spend a lot of time on that because I have so many more important things to discuss. But it's very interesting because actually, first of all, it's very, very complicated. And I only put a little slide of the pie, if you will, just so that you understand the mechanism for some of the drugs that we use. But it's more complicated than that, and I don't have time to cover it. And I know you're very interested, so your book reviews that. So you definitely welcome to go over that. But few things are important to keep in mind. When we talked about bone, and this is important, all as we sit here, we're making new bone, right? And you remember from your anatomy and physiology classes, we have two cells, if you will, involved in bone formation. So the remodeling process involves osteoclasts. You remember what osteoclasts do? Probably not. But osteoclasts, okay, so osteoclasts and osteoglands. So osteoclasts are the ones that take up all bone, right? So that osteoblasts can mineralize that area of the bone with new bone. So pretty much to achieve, and this again, the process of remodeling takes about 4 months, but it constantly happens in millions of sites in your bones at the same time. But what happens is if you have a mismatch, if you will, between osteoclast activity and osteoblast activity, right, then you're going to see decreased bone mineral density, right? So we'll go over some of the drugs and their mechanism of action. But one important thing in one of the drugs that now we use as a first-line agent actually binds to specific area on the osteoclast and actually prevent the activity of the osteoclast. And this particular slide go a little bit over that. So it's very interesting because osteoclasts, and again, they're looking at many different areas, but research in this area is kind of slow, and because the outcomes, as we will see shortly, are not as good as we would expect they would be. As I was going to say, I'm just going to mention this briefly so that you understand just this particular drug, but there's a lot more behind it. So there's so osteoclast actually has, or if you would precursors of osteoclast have this receptor called rank receptor in their surface. And what happens is when a woman becomes menopause, the osteoblasts actually upregulate a rank ligand that actually activates osteoclast activity. So what happens when you have increased osteoclast activity, but normal osteoblast activity? You have increased resorption of bone, but not increased mineralization of bone. So certainly, as we will see, one of the targets to decrease this increase in osteoclast activity is by attacking this RAN surface, this RAN receptor in the osteoclast cell. Now, again, as I said, there's much more than that. In terms of the clinical presentation, a couple of things important to keep in mind is that patients really do not feel that they would have osteoporosis. There's no pain, there's nothing until the osteoporosis is too pronounced, and you'll see very classic clinical symptoms, which we go over. When we look at calcium levels, phosphorus levels, guess what? You think they're going to be normal or abnormal if you have? They're going to be normal. Guess what? That even though you may have this deficiency, guess why your calcium phosphorus levels are normal? Because you're taking it from bone. Okay, so we don't see deficiency in calcium and phosphorus in patients with osteoporosis. The bone is being taken up. So the symptoms that we see is already happening when osteoporosis is already full blast. So this patient, as I mentioned earlier, would have low trauma fractures of the wrist, the spine, or the hip. So sometimes, guess what? Just turning in bed in this patient could lead to a wrist fracture, or holding abruptly into a wall could lead to that. Falls, again, to hip fracture. So we're talking about low trauma fracture. Now, what is interesting, particularly in patients that have vertebral fracture, which again, those that once they have the vertebral fracture could be very painful, they develop a curvature or a hump in their back, and then their abdomen protrudes. So you may have seen in your pharmacy those patients with that very classic hump, very classic curvature and protrude abdomen. And it's funny because when I see them, I always think, oh, osteoporosis, let's look at the calcium. So you have, right, and they use in supplement. And very often, patients actually complain of losing height. They say, oh, I used to be taller. Sometimes they can lose 1 or 2 inches in their height. So it's important that if you have a patient that might be complaining about that, that's very likely related to vertebral compression fractures, and certainly we need to address that in terms of what we can do for treatment and prevention of further fractures. In terms of the diagnosis, as I said, you can do the diagnosis clinically. If a patient has a low trauma fracture, you don't really need to get bone mineral density testing to diagnose the patient as having osteoporosis. You can get your regular tests to make sure, for example, that the patient is not hyperthyroid, or obviously that doesn't have vitamin D or calcium deficiency, and we can talk a little bit about that for other reasons. When you read in the literature for osteoporosis, there's all sort of markers, as I was trying to explain earlier, all sort of markers of bone turnover, but really they're just useful in experimental settings. We really don't use this test clinically. There's a lot of variability in results, and we don't really know how would be the best way to interpret these results. And they don't necessarily translate with fracture risk. And we'll briefly, again, review that again when we talk about monitoring therapy. So they're not helpful in the diagnosis. So really the diagnosis objectively can be determined by doing a DEXA scan and using the T-score. So I'll briefly explain that in the next slide. So as you imagine, these are expensive testing, so there's specific recommendation to use this test. Who should be tested? The recommendations are to test anyone that is over 65 if they're a woman, over 70 if they're male. If the patient, and we'll talk a little bit more about this FRAC score, if the patient is younger than that, particularly if they're between the ages of 50 to 59 and may have increased risk factor by the FRAX score of more than 9.3%, those patients should be screened. Or any patient, no matter the age, if they have a low trauma fracture, certainly they should be tested. Now, in terms of the diagnosis, how this works, I'll briefly explain this. So we know that when we look at the bone mineral density, we have an idea of the fracture risk that this patient may have. Now, one thing to keep in mind is that increasing bone mineral density does not necessarily translate in decreased fracture rate. So even though we look at bone mineral density to predict the patient risk of fracture, when we give therapy, we may not always, even though we're increasing the bone mineral density, produce good bone. And we see some of that when we talk about the different agents. So we know that for every one standard deviation decrease in bone mineral density, the risk factor for fracture increases about 1.5 to 3 times. So what we do is we look at the bone mineral density at the spine, the femoral neck, or the hip, and we see that and we compare the patient bone mineral density to peak adult mass, and we call that the T-score. So if we see a decrease in 1 to, I guess 2.4 in bone mineral density, we call that osteopenia. So minus 1 to minus 2.5, that is osteopenia. If the patient has a T-score that is more than minus 2.5, does that make sense? It's hard to say with negative numbers. Then that patient is actually diagnosed with osteoporosis, okay? So it's important to keep that in mind, because when we looked about how to monitor this patient, this bone mineral density number becomes a little confusing. So we'll briefly go over that as well. And the recommendations keep changing. So this is actually, when the results come back, the results are pretty neat, depending if they have done a vertebral fracture assessment. You can actually see the compression fracture. It will give you the T-score for that patient. Actually, what does this patient has from minus 2.7 to, I don't know, minus 0.14 and no more 3. Is that osteoporosis or osteopenia? Big time osteoporosis, right? And it could tell you, you can actually look at the bone mineral density in grams per ml and take a look at that. But anyway, so yes, so the official diagnosis of osteoporosis can be done clinically if the patient has a fracture, or we can get bone mineral density testing and assess again if the patient has osteoporosis or osteopenia. So the ultimate goal, obviously, of treatment would be to prevent fractures. So not necessarily, and this is important, is to increase bone mineral density. As we know, some therapies that have been in the market increase bone mineral density, but not necessarily fracture risk. So the ultimate goal that we want to achieve is prevent fracture. One of the important thing is we could try to, again, stabilize and hopefully achieve some increase in bone mineral density with drugs that we know translate into lower risk of vertebral or hip fractures, and we'll go over that as we go over the treatment. Hopefully prevent those deformities that we talked about, and very important, particularly in the elderly patient, maintain functional physical function, because again, vertebral fracture could be very debilitating, and as I said, hip fractures, the morbidity and mortality associated with those are very high, particularly we're just talking within the first year of the fracture. So what are some of the universal interventions? And again, very important. So I'm telling you these numbers, not just for your patients, but for you. Very important to engage in regular exercise. And we're talking about weight-bearing exercise. So for example, swimming is not that good. Stop smoking, stop drinking too much. prevent falls, particularly in terms of our role, try to, in the elderly, avoid medications that may cause sedation, you know, dizziness, that sort of things, and also making sure, you know, any vision changes in the patient or hearing changes, and certainly many of these patients require an assessment of the household to make sure, you know, that they don't have rocks that they can trip over and that sort of things. And then in terms of medication, obviously this patient needs to ingest the right amount of the recommended daily allowance of calcium and vitamin D. If you look here, for women 51 to 70, the calcium requirement that needs to be met is 1,200. This is for female, about 1,000 for male. For younger patients, your age, guys, you need at least 1,000 milligram per day of elemental calcium. So we'll talk about that. Make sure your multivitamin has some of that. For vitamin D, for the 51 to 70, about 60. It's actually quite interesting. Depending on what guideline you're looking at, and your book kind of addresses all the difference in the guidelines, so I'm just gonna go to what the RDAs are, but the National Osteoporosis Foundation recommends vitamin D between 80 to 1,000. These guidelines were revised in 2010, and the upper limit of intake for vitamin D is 4,000. However, we really don't want patients to be taking 4,000 units of vitamin D daily. Oh, I'm not even moving. And I say this because we can see these products over the counter, so you do have to be careful and warn the patients about, you know, eventually potential toxicity. So keep in mind those RDRs, not just for your patients, but also for yourself. In terms of calcium, a couple of things important to keep in mind when we're talking about calcium supplementation. Even though we're talking about this patient requiring, excuse me. Even though this, can you hear me? Can you still hear me? Okay. Even though we're talking about this patient requiring 1,200 milligrams of elemental calcium, it's important to keep in mind that we cannot give all that at once, okay? So the maximum dose that you're gonna give is about 500 to 600 milligrams, because otherwise you won't absorb it. So we're talking here, if the patient needs complete supplementation, which we will do if the patient is being treated, then we need the calcium to be dosed twice a day. Couple of things important here, calcium carbonate has acid-dependent absorption, so you should tell your patient to take the calcium carbonate with breakfast, right, with food, and with dinner. Sometimes you have to move it a little bit if you're patient, right, because of drug interaction, takes all the other meds in the morning, so then switch it to lunch and dinner, but it's again important to keep that in mind. Calcium citrate and calcium phosphate are acid independent, so that might be an advantage to some patients, so they can take it on an empty stomach. The problem is that calcium phosphate not necessarily is that well absorbed, even though, as we will see in the next slide, has a higher percentage of elemental calcium, because the calcium and phosphorus complex may decrease the absorption. But when we look at calcium citrate, actually it has the lowest percent, okay, of elemental calcium. So actually, as we will see in the next slide, those patients need to take 2 tablets 2 times a day if we want to give them the 1,200 milligrams. So please don't be fooled by that. You probably see all these commercials, I don't know, on TV about, okay, this calcium is better with your pharmacist, so you do know better. In terms of interactions, yes, it decreases the absorption of iron, thyroid, very important. You don't want to forget those, phenytoin, bisphosphonates, and quinolones. And then if the patient is in PPI or an H2 blocker, that could decrease the absorption of calcium carbonate, so then that wouldn't be helpful for you. Side effects, very much minimum. Some patients may complain of constipation, so you may have to adjust the doses based on that. The incidence of kidney stones are very, very questionable, up to 17%, but and usually you don't have concern unless the patient is eating over 2,500 milligram per day. In terms of, as I said, the calcium, elemental calcium per tablet, calcium carbonate has about 40% elemental calcium. When we look about calcium citrate, it's only 21%. You notice that all those citracol is like citracol maximum, citracol whatever. It doesn't tell you the amount of elemental calcium. Read the label in the back, okay, for that specific product, because yes, you need to make sure that the patient is taking the right amount. A lot of my patients, and probably a lot of yours, complain about the size of the tablets. So if they have to take 4 tablets, that might be a concern if they cannot swallow that. And then calcium phosphate had about 38% of elemental calcium, but again, the absorption could be decreased. So calcium carbonate and calcium citrates are usually more commonly used, keeping in mind that you have to make sure your patient gets the right amount. In terms of vitamin D supplementation, a couple of things important to keep in mind is that we do want the patient to have enough vitamin D. Vitamin D, really we don't have that many dietary products that have vitamin D, so certainly, particularly this population does need vitamin D supplementation. There are 2 different vitamin D, 2 different types of vitamin D, vitamin D3 and vitamin D2. They're both over the counter. The 1,25-dihydroxy vitamin D, that's really not a vitamin D supplement, that's a prescription. We use that more for renal patients. So most patients we can supplement with OTC vitamin D3 products. Now we have some patients that may have deficiency of vitamin D that may require not just supplementation but treatment. So usually vitamin D levels are we're gonna be obtaining patients that are at high risk for vitamin D deficiency, like elderly patients that are housebound, chronically ill patients that may have kidney insufficiency or malabsorption syndromes, and patients that may have medications that decrease the absorption. So in those patients, if they have vitamin D level, and I have to tell you guys, this number changes and it's possible that change over time, but currently, if the patient has vitamin D levels that are less than 20 nanograms per ml, then those patients do require prescription, okay, not over the counter, but prescription regimens. And usually we'll see, like 50,000 units twice a day for 8 to 12 weeks to replace the vitamin D. And then certainly those levels need to be repeated, but because if you remember vitamin D is a liposoluble vitamin, and the half-life is prolonged, we wait about 3 months or so when the patient will be at steady state. But this is not really what we're talking about, treatment of vitamin D deficiency. I just wanted to point out that you may see patients require those prescription doses because they have low vitamin D levels. So what we're talking about is calcium and vitamin D supplementation that we can do with over-the-counter products to maintain RDA recommendations and prevent fracture rates. And again, if the patient is treated, then certainly it needs to be treated because they need to receive calcium and vitamin D supplementation because that's the way the products work. Now, in terms of recommendation, like for drug therapy for osteoporosis, so as I said, calcium and vitamin D supplementation, everybody should get it, that they don't have the recommended RDA, regardless of their age, right guys? But certainly those recommendations changes, or the number changes depending on the age of the patient, and you should give them calcium and vitamin D supplementation if they don't need those RDAs. How do we decide to give drug therapy for osteoporosis? So patients that should be considered for drug therapy would be anyone that present, that is over 50, right, that may have been menopause, keep in mind that, again, men also can develop osteoporosis, so we should consider therapy in patients that have osteoporotic fracture of the hip, of the spine. If we have a patient that has a osteopenic T-score, those patients as well be considered, and we're talking about, again, hip, neck, or spine. And then patients that, I should say that have osteoporosis. Patients that are osteopenic, those patients, the treatment really will depend on the FRAX score, and I'll explain that in the next slide. So if you have 10-year risk of 3% for hip fracture at 10 years, those patients should be considered for treatment, or if they have a probability of any osteoporotic fracture of 20%, those patients could be considered for treatment. When you do DEXA scan, those 10-year fracture risk is actually calculated, or you can actually calculate it. There's a FRAX calculator online. There are also apps that you can use. So in other words, you would consider treatment for anyone that may have an osteoporotic fracture, anyone that has osteoporosis by T-score, or anyone that has osteopenia and has an increased risk of fracture based on the FRAX score. The FRAX score, you don't need to memorize this. We already went over the risk factor, and there are different FRAX calculators depending on the country. The one that we use here was revised in 2014 and include things like the gender, the prior history. Obviously, we include the bone mineral density, and that's why you do get bone mineral density. Those will be calculated. Alcohol intake, and so forth. So this is just for your reference, but you can see certainly that the risk factors that we discussed earlier contribute to the calculation of the risk factor for any type of osteoporosis fracture. In terms of treatment, actually, when we look at treatment, I think that the recommendations for treatment are pretty simple. So we'll go over what the agents are first, and then we go over the recommendations. So keep in mind that some of these products have been approved for treatment. Some of the products have been approved for prevention. And sometimes when we look at the prevention, particularly for some of the bisphosphonate, the doses for prevention are lower than the doses for treatment. And also, some of the products are only indicated for treatment, so it's important to keep that in mind when selecting therapy. When we treat patients with medications for osteoporosis, right, as we will go over, every patient needs to supplement for calcium and vitamin D. Okay, so this patient absolutely needs to be on calcium and vitamin D because that's the way the products were studied. Some of these products cause hypocalcemia, and if you don't have calcium and vitamin D, certainly the outcome is not going to be the same as in the clinical study. So we'll start with biphosphonate. The biphosphonate, again, they inhibit osteoclast bone resorption, and they had shown, and this is important, just alendronate and resindronate had shown to decrease the incidence of retrieval and hip fracture. Why am I pointing this out? Because when we look at evandronate or Boniva, the agent at the bottom of your slide, this particular agent don't have fracture, hip fracture data. And the reason why is this pertinent? And what do you think it had been approved? What do you think they looked at? Bone mineral density. So it just increases bone mineral density, and because it's a bisphosphonate, and we'll talk a little bit about some of the issues with bisphosphonate next. Well, now if I hold my hand, I can move. Then it's important to keep that in mind because we don't really, remember the ultimate outcome is to show improvement in hip fracture rate, not really increasing bone mineral density. And that's important because certainly it would affect your decision in terms of picking up an agent in a patient that has osteoporosis. As I mentioned earlier, the doses for these agents could depend on if we're using it for prevention, or in other words, patient with osteopenia, or we're using it for treatment, patient with osteoporosis. Bisphosphonates stay in bone for a prolonged period of time, so most patients are going to be in weekly doses for alendronate. And you can see here again that, for example, for alendronate treatment is 70 milligrams a week, while 35 milligrams a week for prevention. The doses are here for your reference. You do not need to memorize the doses. You don't need to ask me again, not changing my mind. But what I'm trying to tell you is that to just be aware of that. If your patient has osteoporosis or osteopenia, the doses will be different. Couple of things very important, guys, again, for you to know, because you're going to be pharmacists helping these patients, is concerns in terms of ADRs and how to avoid the ADRs. Very important, and also absorption. That biphosphonate, I mean, if we're talking just once a week administration, it shouldn't be that big of a problem. We tell the patient, take it every Sunday or whatever day might be easier to do this. It needs to be taken at least 30 minutes before the first meal of the day. So it cannot be any kind of food, including seltzer water. It has to be with plain water, okay? Not even that, because that decreases the absorption. So it needs to be taken with at least 8 hours of plain water. Not juice, not milk, nothing like that. And very important, you tell the patient to be upright for at least 30 minutes. They cannot go back and lay down, right? If you think you cannot eat in 30 minutes, you go back to sleep. You cannot do that. Because, guys, this is associated, particularly in elderly patient with esophageal ulcers, okay? So they need to stay either sitting or standing. They cannot lay down. So very important. I mean, there are different products, but certainly that's for most products. As I said, they cause esophageal ulcer, they cause hypocalcemia. Very important, they can cause osteonecrosis of the jaw. And this could be very, very severe. It's interesting because we see this mostly in patients with malignancy that have undergone dental treatment. But it could happen to any patients, and it actually decreases, particularly if they have gone to dental procedures where the mucosal of the mouth doesn't really heal, and it exposes the jawbone. So again, if you look at some of the pictures, I don't want to have any copyright violations, but you can look them up. It could be quite significant. So it's important to keep that in mind. The other important thing, and this is a new thing we saw after the products had been in the market, is that this patient could have spontaneous, low trauma femur fractures. So femur fractures is a large, long bone, right? It's not your vertebral wrist. And sometimes this patient have no symptoms. Sometimes they may have pain, but they could be walking and they just have an atypical fracture of the femur. We see this with prolonged duration of therapy. We see this in patients that have been on biphosphonate for 5 years or longer. Remember when I told you it increases bone mineral density, it decreases fracture rate, but it seems that still the anatomy of that bone is not the same natural anatomy of the bone. We're seeing this atypical fracture rate, femur fracture. So it's important to keep that in mind, and that's one of the reasons, as we will discuss shortly, that the treatment of osteoporosis with biphosphonate should be prolonged beyond 5 years. In terms of contraindication, obviously if your patient has any GI problems that would be exacerbated with this kind of irritant agent, obviously that will be contraindicated. And very important is not, although there's some data in osteoporosis on renal patients, it should not be and it has not been well studied in patients with creatinine less than 35, so that's an absolute contraindication at this time unless the patient is in a study. There are two intravenous phosphonates, zoledronic acid and eventually. They're very, very expensive. Zoledronic acid or reclast is just an infusion that you can give once a year or every 2 years, very expensive. It's a pain to get it covered by Medicare. You probably have to deal with that. But again, those agents will give you the advantage of not needing to use pill once a week or once a month, but again, very costly. So again, those patients that will use biphosphonate need to be counted appropriately in terms of administration. Make sure you don't have, the contraindications, be aware of those, and certainly the side effects, so you can hopefully choose the right therapy in the test. Okay, the next agent is denosumab. This is a monoclonal antibody that binds to the rank ligand that we talked about earlier, and because of that, it inhibits osteoclast proliferation. So again, very effective preventing that upregulation of osteoclast. However, well, let's talk first. This agent decreases vertebral and non-vertebral hip fractures. And in terms of the indication, should be used in those patients that have increased risk for fracture, had the history of osteoporosis fracture, or may have been intolerant or contraindications to biphosphonates. As we can see here, is a subcutaneous injection that is injected by a health professional, even though it's subcutaneously. It's not something the patients do themselves every 6 months, and absolutely it decreases calcium. It needs to be, the way it was studied is with at least 1,000 milligrams of calcium and 400 milligrams of vitamin D. As I mentioned, this can cause hypokalemia, so it's important to supplement this patient, and again, if you don't supplement them, you may not see the same outcome. In terms of some of the side effects that we see with this product, patients do have higher risk of UTIs and cellulitis, or even endocarditis that leads to hospitalization. So these elderly patients do need to be monitored closely. Once again, that osteonecrosis of the jaw also occur with this product, so it's not a side effect limited just to biphosphonate. So very important that before this product is used, that the patient actually get their dental examination, that any dental treatment be done ahead of time, because again, we see this particularly after patient had gone to get procedures, dental procedure. And once again, we see the atypical femur fractures. There's some data using this up to 8 years, but again, the same concern that we have with the bisphosphonate, which again limits the duration of therapy. And we, again, this is a newer product, so they're still doing surveillance, or you should report the side effects if you have a patient in this therapy. The next agent that we'll go over is a recombinant parathyroid hormone of Forteo. This again is not used as a first-line agent. The problem, well, we'll go over the problem in the next slide. The indication are listed here for you. These are usually patients that, again, cannot tolerate bisphosphonate, or the use of, or may have significant decrease in bone mineral density, or may have a significant increase in fracture rate. This is again not a drug that we use early. It's again very costly. It is a subcutaneous injection daily. The patient injects this themselves. It comes in a special pen that needs to be actually refrigerated. And the duration of therapy should not be more than 24 months. The reason for that is because it has a black box warning that we saw an increase in the risk of osteosarcoma in animal studies that is higher with higher doses and with increased duration. So right now, remember we talked about the other agents to be used for about 5 years. This agent is just for selected patients that cannot tolerate previous therapy or are very significant decrease in bone mineral density, but it cannot be used for more than 2 years because of that concern. Certainly, there's a registry, and we're looking, and this being studied. Also, this product is extremely costly. So if you get this patient in one of these products because of the indications that we talked about, this patient, very hard to get this approved, and then they get into that donut hole of Medicare, and then they cannot afford their cardiac medication, so certainly this is something that you need to consider. Contraindicated in patients with end-stage renal disease, it contraindicated in patients that may have orthostatic hypotension, because usually we see this significant orthostatic hypotension with the initial doses. This patient may develop arthralgia, may develop pain at injection site, and as I said, it's very costly, and it can only use up to no longer than 2 years of therapy. The next agent is calcitonin. Calcitonin is quite interesting because it's only approved for treatment of menopausal women, or treatment of osteoporosis in menopausal women that have been at least menopausal for 5 years. And the reason for that is because it doesn't help, it doesn't prevent bone loss in women that are before 5 years of menopause. It does have data in decreasing fracture rates in women that have osteoporosis, or even in women that have had previous fractures. The problem is that this agent, patient developed tachyphylaxis to this agent within 1 or 2 years, so it really cannot be used longer than that. One advantage of the product, and maybe probably their role in therapy, is that it improves the pain of vertebral fractures. Certainly, it can be, and actually, it improves the pain of vertebral fraction right away. This is not something that we see over time. So it certainly can be used to prevent the pain of vertebral fracture, however, it's quite costly, and sometimes, obviously, we can treat this with less expensive therapy. So it's not really, okay, you have vertebral fracture, we'll give you calcitonin to improve your pain, but certainly something that could be considered if the patient is not responding. It's an intranasal formulation, and once again, it causes hypocalcemia, so very important that patient be supplemented once again with calcium and vitamin D. Raloxifene is actually an estrogen agonist antagonist, quite interesting medication because it does decrease the risk of vertebral fracture, and however, the data on hip fracture, which I feel that if you review the literature, I think they have a type 2 error, but the studies really did not show that it decreased vertebral fractures. So as you would imagine, being an estrogen agonist antagonist, right, we have the same concern that we discussed earlier, but very important to keep that in mind because, again, it's just as, it would have the same contraindications that we talked about earlier. If we look at the recommendations that I'm briefly going to discuss next, this drug really should not be used for osteoporosis alone or at all. However, it's quite interesting because it's indicated for the treatment, not treatment of osteoporosis. And what is very fascinating is that actually in women that have risk of breast cancer, it actually decreased the incidence of breast cancer, reduces the risk up to 95% in women with estrogen-positive breast cancer. So In that population, that might be something that you will consider. However, in general, again, it's an estrogen product. We don't want to use it for chronic treatment, as we discussed earlier. Other important consideration with this is that it causes hot flashes and increases the risk of VTE. The risk of VTE is increased like 3 times. So they ask patients that when you're using this medication, don't stay sitting down for too long. In terms of hormone replacement therapy, we already went over this. Guess what, guys? We should not use it for chronic therapy. We should use it right short term for menopausal symptoms. You will see that a lot of products have the indications for prevention and treatment of osteoporosis, but certainly not something that we consider. There are also a lot of recommendations. The latest recommendations were from the American College of Chest Physicians, and these few things here summarize how we should use osteoporosis medication. Alendronate, rexindronate, cellulonic acid, and denosumab are your first-line agents because we have data to reduce hip and vertebral fracture. Once we start this patient on these agents, the duration of treatment should be for 5 years. These guidelines suggest that we do not check bone mineral density. Part of the reason for that is because, as you see on my next slide, when we look at bone mineral density, usually we don't see a change in bone mineral density. Some recommendations suggest that we look at bone mineral density every 2 years, and if we don't see a decrease in bone mineral density, we're good, right? Because over time, the decrease in bone mineral, you will see a continuous decrease in bone mineral density. So if your bone mineral density is as good as baseline, you're doing a good job. However, these guidelines were just published, actually they were published last month, recommend that bone mineral density do not be monitored. And again, very important, this recommendation, different from the National Osteoporosis Foundation, recommend that hormonal replacement and raloxifene do not be used for the treatment. Again, we have more data now, the possibility of breast cancer in this younger population. So with that, that kind of summarized the treatment of osteoporosis. And the last slide, just go pretty much over, this is from your book, summarizes a little more clearly all the things that we talked about osteoporosis. So anyway, guys, I'll see you, I guess I'll talk to you on Sunday with some of you, and I'll see you Monday in the test. Please study, it's gonna be easy, but you need to study, don't get me down. Okay. Have a good week.
I'm going out. But like sometimes if there's a week, that's a week for like
And like should the Facebook event is like start to share or is it gonna go on later?
I just registered a flyer instead.
Streaming services.
I know.